Welcome everybody to this RIC. Today I'm delighted to welcome Dr. Elaine who's an associate professor of medicine in the Department of Medicine here at Oregon University. Dr. Lam obtained her medical degree at the University of Colorado, and then was also a resident, active resident here. She subsequently went to Ohio State University, where she was a fellow and also a chief fellow. Dr. Lam is widely published in research related to renal cell carcinoma and prostate cancer, where she leads multiple clinical trials. And she is also the cancer research medical director at UC Health Cancer Center at the Highlands Ranch. And so, Dr. Lam, thank you so much for coming. Pleasure having you.
Thank you very much for having me and inviting me to speak today. We normally have two speakers, and since there's one, I made my talk a little longer today. So today I'm going to talk to you about the approval process and just the drug discovery story with Belzutifan for patients who have VHL syndrome and VHL-associated tumors. My relevant disclosures, I do receive, I am a principal investigator of multiple trials that get institutional research funding from Peloton Therapeutics and Merck. Both these companies are involved with the development of those. So the outline for today's talk, first I'll talk about von Hippel-Lindau syndrome, then what the VHL gene is and what it does, and then also targeting the hypoxia-inducible factor. I'll start with the case. This is a patient of mine who's 35 years old now, but patient with von Hippel-Lindau syndrome. So he presented at age 18 with nausea, vomiting, dizziness, headaches, and was found to have a cervical medullary junction mass. That was resected and found to be a grade 1 hemangioblastoma. He subsequently underwent genetic testing that confirmed VHL syndrome. And in addition to the CNS hemangioblastomas, he also had manifestation of pancreas and kidney cysts, as well as epididymal cysts. And in the last 17 years, he's undergone multiple surgeries and radiotherapy treatments for hemangioblastomas that continue to recur. And about a year ago, he had an MRI that showed mild progression of a spinal hemangioblastoma. So here's some images from his initial diagnosis, the cervical medullary junction tumor there. Here's another view of that. He also has kidney cysts seen here, and then pancreatic cysts as well. Okay, so what is VHL syndrome? Von Hippel-Lindau syndrome is an inherited autosomal dominant condition that is present in 1 in 36,000 people. So autosomal dominant inheritance means that you only need to have one gene mutated to exhibit the condition. It also means that men and women are at equal likelihood to inherit this gene, and a child who has a parent with von Hippel-Lindau mutation has a 50% chance of getting it. Von Hippel-Lindau syndrome results in a germline mutation of VHL, which is a tumor suppressor gene. About 20% of cases are actually not inherited and arise de novo in patients who do not have family history of von Hippel-Lindau disease. These patients also have higher risk of both benign and malignant tumors. So this is a figure of the organs that can be affected in someone with von Hippel-Lindau syndrome. So my patient had central nervous system hemangioblastomas involving the brain and spinal cord. Other patients have retinal hemangioblastomas that often require multiple procedures and often lead to blindness. Other patients have endolymphatic sac tumors involving the temporal bone that can lead to hearing loss. And in the abdomen, von Hippel-Lindau disease can manifest with pheochromocytomas and pancreatic and kidney cysts and tumors that can become metastatic. And so these patients often require multiple procedures starting at a very young age, and they also require very close monitoring with labs, imaging, and other evaluations. And there are two classifications of VHL disease. This is based on the likelihood of pheochromocytoma. So type 1 VHL disease, these are people who typically do not have associated pheochromocytoma, and type 2 VHL disease, which has 3 subtypes. Those are patients who have a higher risk of pheochromocytoma. So who were von Hippel and Lindau? So the syndrome was named after 2 people, Eugene von Hippel and Arvid Lindau. Von Hippel was a German ophthalmologist who in 1904 described a rare disorder of the retina. And in 1911, he discovered and described the anatomical basis of this disease and named it angiomatosis retinitis. It's a very blood vessel rich tumors that we see in the eyes and CNS of these patients. And Dr. Lindau was a Swedish pathologist who in 1926 recognized the link between these retinal lesions and also brain and CNS hemangioblastomas. He also described renal cysts and tumors in these patients. And the term von Hippel-Lindau disease actually was first used in 1936. It wasn't until 60 years later that Professor Eamon Mayer actually discovered and described the gene for von Hippel-Lindau disease. And in the ensuing 2 decades, a lot of work was done to help us further understand von Hippel-Lindau gene and the different interactions. So the Nobel Prize in Physiology and Medicine in 2019 went to these 3 people, Dr. William Kaelin, Dr. Sir Peter Ratcliffe, and Dr. Greg Semenza for their work in discovering how cells sense oxygen and how they respond and adapt to situations where there is a lack of or abundance of oxygen. And specifically, Dr. Semenza showed that hypoxia triggers expression of the erythropoietin gene, and he also discovered the hypoxia-inducible factor protein complex. Dr. Kaelin's work primarily was focused on the von Hippel-Lindau disease and the actions of the von Hippel-Lindau gene. And then both Dr. Kaelin and Dr. Ratcliffe demonstrated interactions between hypoxia-inducible factor and von Hippel-Lindau disease and oxygen availability. And these were important discoveries because they led to the approval of the main drugs that we use today for the treatment of metastatic renal cell carcinoma. So a lot of the vascular endothelial growth factor receptor inhibitors that were approved in the early 2000s, and also more recently, the approval of Belzutifan for the treatment of VHL disease-associated tumors. So the VHL gene is located on the short arm of chromosome 3. VHL, as I said, is the tumor suppressor gene, and the VHL protein complexes with hypoxia-inducible factor, which is a transcription factor, and that interaction is oxygen dependent. So in the presence of oxygen, HIP or hypoxia-inducible factor, is hydroxylated rather by choline and asparagine hydratase. And it also interacts in the presence of normal VHL. It gets ubiquitinated by VHL. And so this leads to normal proteasomal degradation of HIF protein, and you don't see accumulation of that protein. In the absence of oxygen, so hypoxic states, or in situations where you have a mutated von Hippel-Lindau gene, those interactions don't occur, and that leads to accumulation of hypoxia-inducible factor proteins, which again serve as transcription factors and resulting in the increased transcription of downstream proteins such as vascular endothelial growth factor, platelet-derived growth factor, and other proteins that promote angiogenesis and tumor growth. Specifically with clear cell renal cell carcinoma, there's increase in HIF alpha protein and subsequent transcription of VEGF and platelet-derived growth factor and others lead to activation and stimulation of neighboring vascular cells to promote angiogenesis, to bring in vessels to create, to bring in nutrients and oxygen that continue to supply the clear cell kidney cancer. And so these tumors, when you look at them, are very, very vascular tumors for that reason. So what's the connection between VHL mutations and clear cell renal cell carcinoma? So we look at all renal cell carcinomas. The 75% of all kidney cancers are clear cell renal cell carcinomas, and the other 25% are non-clear cell kidney cancers that are comprised of these subtypes. And looking specifically at clear cell kidney cancers, you can see that actually familial or inherited VHL disease-associated RCC is a very small sliver of the patients who get it. 2/3 of patients with clear cell renal cell carcinoma actually have a sporadic acquired VHL gene that is what leads to the development of clear cell renal cell carcinoma. And so the same mechanisms that we just talked about for VHL disease is very applicable to patients with clear cell kidney cancer because they have the same gene that is acquired. Okay. And so how do we target the VEGF, HIF, VEGF, VHL, HIF, and VEGF pathway? So for a very long time, even though we knew about the interactions between HIF and VHL and vascular endothelial growth factors, we really had no way to directly inhibit hypoxia-inducible factor. It's a transcription factor, and those are very difficult to target. And so what we had in the previous 2 decades were inhibitors of vascular endothelial growth factor receptor and PDGF more downstream. So sorafenib was the first VEGF inhibitor, VEGF receptor inhibitor approved for the treatment of metastatic kidney cancer in 2005. VEGF specific inhibitor, so bevacizumab or Avastin was approved in 2009. And these 2 approvals were for patients with metastatic renal cell carcinoma. And then last year, the first HIF alpha inhibitor, Belzutifan, was approved for the treatment of VHL-associated tumors. So not just kidney cancer, but others that we'll talk about. Okay. And so the path to Belzutifan approval was actually fairly rapid over the last decade. In 2009, researchers at UT Southwestern developed a small molecule HIF2 alpha inhibitor. They called it PT2399. that targeted the small molecule binding pocket of PAS-B domain of HIP2 alpha. And with this information, a startup company called Peloton Therapeutics took this to further development, fine-tuning, and their first clinical HIP2 alpha inhibitor was called PT2385. And we were part of this first in man HIP2 alpha inhibitor here in patients with metastatic renal cell carcinoma. And so from there was further fine tuning to maximize the PK and pharmacokinetics and pharmacodynamics. And so second generation HIP2 alpha inhibitor, PT2977, was developed, and this is the drug that was subsequently renamed Belzutifan. So in 2018, a phase 2 study was the phase 2 study started, multi-center study led by Dr. Will Nash at MD Anderson and Dr. Srinivasan at the NIH to study specifically this drug in patients who had VHL syndrome and associated kidney cancer. They had to have VHL associated kidney cancer, but they also could have other VHL associated tumors like the hemangioblastomas and pancreatic cysts and tumors and pneumocysts. And those were followed as a separate endpoint in this study as well. Okay. So this is the phase 1 study of the first HIP2 alpha inhibitor, PT2385. As I said, we were part of this study and enrolled patients here for it. And so this was a study in patients who were fairly heavily treated. About 50% of patients had 4 or more prior lines of therapy for metastatic renal cell carcinoma. And then the majority of patients had prior exposure to VEGF receptor therapies. At that time, checkpoint inhibitors were just emerging in 2014, and so very few patients actually had checkpoint inhibitor exposure at that time, about 1/5. And so what we found in this study of PT2385 was that the safety profile was actually very good. Hypoxia and anemia, so on target effects were what we saw. The maximal tolerated dose was not reached, and we saw that above 800 milligrams twice a day of this drug, we really didn't see any additional higher exposure, and we didn't see any further reduction in sort of the on-target erythropoietin effect. So the recommended phase 2 dose was 800 milligrams twice a day. And then subsequent studies were done with this drug in combination with cabozantinib and nivolumab. So this was the response of patients who were treated in this study. So on the left here, this is a graph of the amount of tumor reduction compared to baseline. So the 0 time point is where they started. And you can see that some patients didn't respond at all and had progression. Within this plus 20% and minus 30%, we consider that stable disease. So the majority of patients had stable disease, and then 14% of patients had objective response. So more than 30% improvement or decrease in their tumor, and one patient had complete response. So again, that was pretty good for a new compound, new mechanism of action in very heavily pretreated metastatic renal cell carcinoma patients. And on the right here, it shows the treatment duration. You can see that many of these patients developed, actually stayed on treatment for a very long time. Many patients up to a year and beyond. So that even with stable disease, it was quite durable. And I personally had a patient on this who was an older gentleman who didn't tolerate prior vascular endothelial growth factor receptor inhibitor, didn't tolerate mTOR inhibitor therapy, but on the treatment breaks kept on having recurrent brain metastases that needed to be radiated or intervened on. And so he enrolled in this study and actually remained very stable for about almost 2 years without any further intervention in the brain. And from a quality of life standpoint, he did pretty well. And so, as I said, PT 2385 showed promising results, but then further fine-tuning of the drug was done to achieve even better pharmacokinetics and pharmacodynamics. So Belzutifan was the second generation HIP2 alpha inhibitor, PT 2977, and so it was evaluated in this phase 2 study in patients who have renal cell carcinoma in the setting of inherited von Hippel-Lindau disease. So here are the baseline characteristics. So first of all, you can see that these are patients who are very young, median age of 41, and the youngest patient enrolled in the study was 19. And then the time of VHL diagnosis. So the range was from 4 years to 66 years when they were diagnosed with VHL disease. Half and half, male, female, good performance status. And the majority of these patients had clinical VHL type 1 disease. So the clinical variant that did not have pheochromocyte. And you can see in terms of previous surgeries and ablations, 97% of patients had had prior surgery or radiation for VHL-associated tumors. And many of them had 4 or more prior procedures prior to coming onto this study. In terms of other sites of disease, many patients had, in fact, all patients had pancreas manifestations. Many had CNS hemangioblastomas. 20% of patients also had retinal hemangioblastomas. And those other tumors were also followed as part of this study. Okay, so here are the results. On the top left-hand corner, this is a table looking at objective response rate of the kidney cancer tumors in patients on this study. And so a total of 61 patients were enrolled to this. And you can see that really almost everybody had some decrease in their tumor. And that's shown better here. And so again, 0 is the starting point, and everyone had some decrease in the size of their renal cell carcinoma. There were no patients who had remission who didn't respond at all and progressed. And so about half and half in terms of partial response and stable disease. This graph here is a plot of the rate of growth, rate of change of the kidney tumors. And again, 0 being the time point where patients started the Belzutifan clinical trial. And so gradual increase for most patients, gradual increase over time in their kidney tumors. And then after starting, you can see almost this upside down V-shaped decrease in the size of those tumors. And again, durability of response, and many patients stayed on this study for a long time. And at the time of the initial presentation, you can see many patients remained on study at 18 months, almost 2 years beyond starting. And this is an important figure here. This shows the number of procedures. So as I said, patients with VHL syndrome often have to undergo multiple procedures over time. And so again, this is time 0, and this is the number of procedures that these patients had prior to starting the trial. And so you can see a very stark difference in terms of after starting treatment. Very few patients required additional procedures after they've started Belzutifan. And in terms of side effects, Belzutifan in general is very well tolerated. Anemia and fatigue are the most common side effects. Most of these are mild, grade 1 and grade 2. Very few are grade 3, and very few people actually needed blood transfusions or erythropoietin. What's not listed here is hypoxia, which is something that we also notice in patients on Belzutifan. On the right here is just a look at hemoglobin levels. You can see the most people do have that initial drop in hemoglobin, but it tends to stabilize after the first 2 to 3 months. And so with that 61 patient phase 2 single arm clinical trial in patients with von Hippel-Lindau disease and metastatic renal cell carcinoma, because the results were really so astounding, the FDA approved Belzutifan for not only kidney cancer, but patients who have von Hippel-Lindau disease and other non-kidney, any associated tumors. So this includes patients who have VHL-associated CNS and retinal hemangioblastomas, pancreatic neuroendocrine tumors, and cysts, and renal cysts as well. And this is a follow-up presentation given just last month at the European Society of Medical Oncology in September 2022. Just giving an update on the additional follow-up. So with now 3 years of follow-up, median 3 years of follow-up in these patients, here were their results. The response rates continue to improve with more time. We were actually seeing some patients who had complete response. We couldn't see the tumors anymore. More patients who had partial response. So 2/3 of patients met criteria for objective response, had 30% or greater decrease in their tumor. And then still 1/3 of these patients continue to have decrease. And this is just showing it a different way. This is the data for the non-renal cell carcinoma tumors for patients in this trial. For CNS hemangioblastomas, once again, most patients had decrease, and the objective response rate, so partial response plus complete response, was 44%. And the durability of that response is long as well. For patients with pancreatic neuroendocrine tumors, the objective response rate was 91%. And then a smaller population had retinal hemangioblastomas, but all 12 patients, 100% of patients had a response to Belzutifan. And in terms of response rate and numbers that we look at in the oncology world, these are numbers that we don't see with any other drug, targeted therapy, immunotherapy, chemotherapy. So these are very, very striking. And then again, showing durability continues to be long for these patients. And this is a very impressive, and now with more follow-up, even more impressive look at the procedures. So again, time 0, and many patients required multiple repeat procedures for multiple tumors before starting and then after starting. Many of these patients, again, younger, working patients who are trying to live their lives and have their families, are not having to undergo surgeries for treatment of VHL-related tumors that have grown. And so this is really, really remarkable. So back to my patient. So he started Belzutifan about a year ago, tolerating it very well, has not needed blood transfusions, has not needed oxygen, and multiple follow-up scans have shown ongoing response to not only his hemangioblastomas in the spine and brain, but also pancreas and renal cysts. He's not needed any additional surgeries or radiation. So continuing to tolerate that well. And I'm happy, very happy that, you know, that the story doesn't end there. And so now that we've proven mechanistically that Belzutifan works for patients with VHL-driven disease, and remember, about 2/3 of patients with kidney cancer have inherited, or not inherited, sporadic acquired VHL mutation. The hope is that this drug will have similarly great results in our metastatic renal cell cancer population as well. So there are multiple phase 3 and phase 2 studies being done, and some of these studies we are and continue to be involved with here at the University of Colorado. So adjuvant studies, so these are patients who have already had a nephrectomy, had their kidney removed for localized kidney cancer. And in this study, we're trying to ask the question, is adjuvant therapy, does adding Belzutifan to immunotherapy in this setting help decrease someone's risk for cancer recurrence? And then there's multiple phase 2 and phase 3 studies being done in the metastatic setting compared to different standard of care drugs, and many in the front line and some in the subsequent line. So my hope is that this drug will be similarly, will have similarly good results in our kidney cancer population. It would be life-changing for many. Okay. So yes, so you can see this is Belzutifan, I think truly is a great success story of molecules to medicine. And it took over a century from the initial recognition of symptoms of von Hippel-Lindau disease and to recognizing it as a syndrome, to discovering the VHL gene, and additional work in that gene and how it interacts with other proteins, and to the development of drugs that we have now and for the treatment of metastatic kidney disease, sunitinib, pazopanib, tivozanib, cabozanib, all of those drug approvals and developments would not be possible without this discovery and this understanding of how VHL works and causes kidney cancer. And so, of course, initial studies that looked at the first HIF2 alpha inhibitor and, you know, leading all up to the approval of the FDA, by the FDA of Belzutifan for patients with VHL tumors. And so a lot of persistence and collaboration among multiple scientists over many years to make that happen. And so I'm very encouraged that once we understood the biology and we had the means to take drugs further, that we it didn't take another 50 years to, you know, get studies done and the drug approved. So I'm very optimistic for the future of patients with metastatic renal cell carcinoma in light of this data that we have with Belzutifan for patients with VHL syndrome. All right. So thank you very much for your attention. And again, thank you for the opportunity to come and speak with you today.
Thank you.
I'm happy to take any questions.
Do you have any questions?
Question.
Oh,
You,
go ahead.
I was just gonna make a comment. I mean, you emphasize this a little bit, but just for the sake of everyone listening, I've been an oncologist for 25 years, and back in the day before I specialized, saw a lot of people die of kidney cancer very quickly. I haven't seen data like this in any cancer, not even mine, breast cancer, in 25 years. Not only are the patient's lives going to change, but your life is going to change.
Yeah.
So come talk to me. I'll tell you what it's like to have a clinic full of survivors. Holy cow.
That's great data.
It's amazing.
I'm wondering if any study look at the like a tissue change. I mean the mechanism of the drug maybe is mainly targeting on angiogenesis or on tumor itself.
Mhm. Yeah.
Mouse model or maybe human cells.
Yeah, I'm not familiar with the exact studies being done. I know in the studies done with Peloton, looking at mechanisms, we, looked at on-target effects with erythropoietin levels. There is work done with tissue, looking at just confirming the on-target effects there. I think much more work will be done in the future because we anticipate, potentially resistance to this drug at some point, and so work being done to look at mechanisms of resistance as well.
I saw some combination clinical trial. They combine with like anti-angiogenesis reagents as well as some like immune therapy agents, right?
Yeah, and so the idea is to just take a multiple pronged approach to target metastatic kidney cancer.
To my I'm very impressed that the peanuts, the data from peanuts is kind of amazing. Right?
Yeah, it really is amazing because the phase 2 study with Belzutifan really was just in patients who had VHL disease and kidney cancer, right? But because there's no standard of treatment for these other tumors, and this drug works so well in those other tumors that they continue to follow. The FDA gave it approval for those other conditions too. And actually now in my clinics, the patients that I see for Belzutifan, the majority are actually patients who don't have kidney cancer, but are being seen. We are a VHL Alliance Center of Excellence here at the University of Colorado. So we have a great team of neurosurgeons, endocrinologists, urologic surgeons, medical oncologists, and we take care of these patients. And really, the patients who have brain hemangioblastomas, pancreatic tumors, many of those patients are being seen in our clinics now.
Great talk. This is impressive data. So as the current FDA indication is for people with either VHL related tumors or metastatic renal cell carcinoma, or primary, or what's the actual FDA approval for?
Yeah, great question. Thanks for clarifying. The current FDA approval is only for patients who have VHL disease and any of the associated tumors. We're hoping that in the future, these studies will pan out and we'll have approval in patients with metastatic renal cell carcinoma as well. The phase 3 study with Belzutifan single agent compared to everolimus was just finished, and so the data is being followed. But we're hoping for good results from that and other studies before it gets approval for metastatic renal cell carcinoma.
Okay. I have 2 other questions. So what is this is only specific for HIF2 alpha, but has no effect on HIF1 alpha?
So yes, that seems to, this is a specific HIF2 alpha inhibitor to my knowledge.
And I guess as a pulmonologist, I have to ask, why do patients get hypoxia? You mentioned they get hypoxia with the treatment. Do they know the mechanism?
Yeah, that's a good question, because when we were doing the phase 1 study of PT2385, that was something that we had noticed here at altitude. And so I think the mechanism behind that, I think was evaluated. I am not very eloquent in in describing it, but it's, almost patients, I also have patients who do well here, and then they go to California or Hawaii at lower altitude, and they come back and they have problems. So it's almost like this similar kind of mechanisms that are required for acclimation at altitude that seem to be effective.
It's going to affect pulmonary artery function and ventilation perfusion ratios in this. So that's interesting.
I think that's a mechanism that is important in for pulmonary hypertension as well.
Are there any questions online? No.
No online questions. Well, thank you very much, everyone, for your time and your attention.
Thank you.